I think that what I have today is probably a little, it's more clinically oriented talk, but I will try to have some basic things whenever possible in this. Carotid atherosclerosis is closely linked with stroke. So, and there has basically been established procedures that each time when you see a stenosis, like I showed here, in this case, this is a carotid artery. This image is actually an MR image. This one is a digital subtraction angiography showing the same location, pretty much. You can get fairly good sense of where the stenosis is. And then the current clinical practice is whenever you see stenosis like this, if the stenosis is over a certain level, then you operate on those patients. There is a fundamental flaw of this type of imaging, regardless whether it is done by MR or it's done by the so-called gold standard, in this case, this DSA image is. This really measures the lesion indirectly. This only measures the effect of the atherosclerosis that is actually growing in the wall, not in the lumen itself. But this simply tells you that this part is likely to have lesions. But this does not really tell you whether lesions grow at other areas. And also, this does not tell you what is really in this lesion. And at this moment, a lot of the research are aimed at looking at the lesion itself because fundamentally, people believe the lesion, especially its contents, is going to have a lot impact of whether this lesion is stable or unstable. These are some sampled histology images of a plaque. This is really not coming from this one, but it's just example of saying, if we started looking at a wall, what do we see? And this is pretty much the gold standard of things. You can see that you see a lumen here that is narrowed. This is where the plaque is. You also see that the plaque itself can be the tissue type within the plaque can be highly complicated, especially in the carotids, where this is a relatively large artery in human. So as I have said, that stenosis, even though it is the factor now used to determine whether this patient, how the patient should be treated, this clearly is based on major clinical trials that this basically shows it is not enough, the information. So if we believe that the stenosis is not enough to look at this, then what should we look at? Especially from imaging point of view, what information do we truly need? This is more a composite drawing of what we believe that we should be looking at. This is a simplified model of what a diseased artery is supposed to look like. This is the remaining lumen. In this case, it's very narrowed. This was the original wall. And then in between this, you can have many different types of tissues. In particular, you can have lipid deposits. You can have areas that is fairly hemorrhagic. In other words, that blood can actually get into those areas. And heavily calcified areas. I don't know in Atlanta region that in Seattle you constantly listen to these radio commercials of asking people to do CT scans. They're really primarily looking at calcium, and calcium is a pretty dominant feature in plaques, in carotids also. So as far as from imaging point of view, that we sort of have looked at this pretty extensively. At the beginning, I must say that we really were just looking. We really don't have anything fixed in mind of what we're looking at. But gradually, this seems to be migrating into three areas. One is to look at something called fibrous cap, which really is showed very nicely of this image here, that this is, in histology, it's a blue layer of fibrous tissue that separates the lesion bulk, in this case, to the lumen. And if you think about this intuitively, you can imagine that if this cap is very strong, in this case that it's fairly thick, and then the plaque is likely going to be relatively stable. In other words, it's not likely going to rupture. Rupture in carotids really is the event that triggers either stroke or TIAs. But if you look at the lesion on the right side, this has a narrowed lumen just like this one. But if you were to look at this, there's really no cap in this case, and it's completely ruptured. This entire region here is filled with blood. It's an intraplaque hemorrhage. So if we have a way from imaging point of view of knowing the differences of these two types of plaques, we clearly can tell this one will have a very different future than this plaque here. And then for the tissue composition, this is a list of tissues that are very quick. You will see this very frequently in carotid lesions. Start from fibrous tissues that may include what I just showed. There's a nicely formed fibrous cap, and also can include other fibrous tissues. Intraplaque hemorrhage, lipid. A lipid can be fairly complicated because it could stay as a so-called free cholesterol that actually is physically in crystalline shape, and can also be cholesterol ester. And usually cholesterol esters can be formed in droplets. This means a lot to MR because MR signal is very sensitive to so-called liquid phase signals, but it's not very sensitive to solid or crystalline phase materials. So this basically tells you if you were to look at lipid in this case, you can get highly variable signals depending on what kind of a cholesterol you see. Also, you have dead tissues, necrotic tissues, and calciums. These are two examples, again, coming from histology of how messy a plaque can be in the carotids. The third area that actually imaging can potentially be used for is to look at this phenomenon. This is called expansive remodeling that was first reported in coronary arteries by a famous pathologist based in Chicago, Glygoff. The idea is that when lesions start to develop in the wall, it doesn't really impact the lumen at all, rather than the lesion grow outwards. And then this process at a later stage will start to impact the lumen size and becomes in this final stage lesion with a tight stenosis with a large lesion bulk. What is really interesting, it turns out, is if we have a way of looking at the lesion at this stage, we're much likely to treat them much earlier in the process and reverse the entire process, so they don't even have to go to this point. And with the current diagnostic tools, if we simply are looking at lumen, we're going to miss all lesions in this stage. And especially in coronary arteries, we're missing a lot of information by not looking at where the non-stenotic part of the artery is. So for us, the motivation of doing carotid artery, as I've said first, is this is an area that the atherosclerosis here is directly linked with a stroke or TIAs, or the so-called transient ischemic attacks. The second one, from the imaging point of view, is that these arteries are rather superficial structures. So we can actually get, using so-called surface coil technologies in MR to try to get as much high signal as possible that can be translated into better resolution images. And the third thing in this is an area that the current treatment for advanced lesions has been doing surgery. When you do surgery, that the plaque actually is removed from the patients, and this is what you see as a plaque removed from the artery. The vascular surgeons at our institution has developed this technique, actually remove this lesion completely intact. So the lumen is actually preserved in this case. And once you have the specimen, what you can do is actually you can do all the histology you want to that. That is critical for the imagers like us, because in order for us to make any statement about what we truly see in human artery, we have to have references. In this case, we truly can use the specimen as the reference to say that what exactly we see in vivo is truly that what we see in this histologic studies of the specimen. This is why that we choose to use carotid to do the study, that if you were to look at all the vasculatures in the body, this is truly the only artery you can get this from alive patients. From other places, you cannot really get very nice specimens like this. And once we do this, we also have developed a pretty extensive way of looking at histology, that we basically make the entire specimen prepared for histology, and then the sections are cut along this entire segment like this. And once they're stained, they can be digitized, and the digitized ones can be basically outlined by pathologists of what tissues and forms a 3D map like this. If you were to compare that MR images versus the other image modalities, why MR is better in this case, that first of all, this is completely non-invasive. And then this has very good soft tissue sensitivity. And also MR images, really, if you think about MR signal, that MR signal is sensitive to both stationary tissues, that most of the like brain, such tissues, and also that MR is very sensitive to flowing tissues, in this case blood. So you can actually try to use MR images to highlight where the blood is, as in the so-called techniques of MR angiography. Also, you can do anatomical images to look at the structures specifically. In this case, that we believe we can actually, we should be able to use both the so-called stationary sensitivity and also the flowing information to look at the vessel wall more comprehensively. This is a picture of a human carotid MRI, and this actually shows what the lesion looks like on MR images. In this case, this is the internal carotids, and this is the external carotid. If you were to look at external carotids, it's easier to understand. This is the near normal lumen, and this is the wall. It's a bright ring here, is the wall, vessel wall. You should see similar things if the internal carotid is normal. But rather, what you see is a very narrowed lumen like this right here. And then you see this entire region is all filled with lesions. That's really the plaque bulk in this case. Clearly, you can see that MR can see a lot by simply looking at this image. But the MR does have plenty of these advantages. The first one is the scan time tend to be fairly long, especially comparing with CTs or ultrasound in this case. MR is, you can get images of this type in several minutes, rather than you can get images, if you have a technique that can get images in real time, that certainly would be much better. Also, MR is relatively expensive. So if we were to, down the road, trying to use this kind of a technique as a screening tool, that we certainly will need a lot of engineering input how to make this as a fast, effective way of doing the screening. The goal of our research has been in two areas. One is that we're interested of distinguishing vulnerable plaques from stable plaques. So-called vulnerable plaques are the plaques that are likely to rupture. And those are usually the ones that cause symptoms. And we hope that by differentiating these two groups of plaques, we can identify surgical candidates from the non-surgical group with a better criteria than the current clinical standards of using stenosis as the criteria. So we can eliminate some of the unnecessary surgeries. If a patient who has a lesion that actually is causing tight stenosis, but if the lesion is actually stable, then those patients probably should not go through surgery, rather than they should actually be treated otherwise. And also, we're hoping that we can use this to identify those patients who may have a lesion that has not really caused severe stenosis yet, but they may be vulnerable to rupture. And those patients, if we can catch them early on, we can treat them much more effectively. We're also hoping that we can use carotids to predict coronary artery disease in some fashion, especially that there have been pretty extensive reports of using ultrasound carotid imaging as a predictor of looking at coronary disease overall. That we believe that the direct measurement of carotids, as we're doing with MR, should be a better predictor in this than what ultrasound can provide of simply looking at the vessel wall thickness. The second thing is, in order to do this work effectively, what we truly have to do is we truly have to provide quantitative indices of what we see in a lesion. This can be translated in terms of the size of the lesion, the volume of the lesion, thickness, those type of things. Also can be translated into tissue composition indices, such as the percent of lipid and where they are, and so on. So this part is heavily image processing based project, because that we believe that we have to have a semi-automatic way of looking at this, and we have to be able to generate quantitative information of what we see in MR images, such that those information can be used to follow patients over time to see that how this process actually evolves over time. This is a series of publications coming out from our lab, pretty much, of looking at this. This has looked at, if you were to look at this, that each one sort of a look at a different aspect of this development. This paper was published in the first Nature Medicine issue that was looking at a rabbit model. We basically showed in this study that you can use MR to follow patients serially. And you can actually see, not only follow them serially, also you can actually see the changes of a lesion with MRI. Since then, we have looked at whether we can measure plaque size based on MR and look at specifically fibrous cap. And also later on, we started to look at whether that we can use MR to determine lesion types, that this is American Heart Association's lesion type definition, whether we can actually use MR to also determine those lesion types. So this is pretty, as you can see that here, that we have basically trying to look at different aspects based on a developed technique of using MR to look at this. So I would like to do next is actually talk a little bit about the technique that we're using. First of all, that because of the carotids are rather superficial, MR really is a technique that where the signal are sampled through coils. In this case, that we built those coils that try to make them as close to the human subjects as possible. That these are the two coils that is sitting on either side of the patients. And you can pretty much place them on the neck on patients. And the surface of these coils are actually flexible. So you can bend it slightly by looking at adjusting that to certain shapes of patients. We also have this pretty nice design head holders, and this actually is an older model of the head holder we have. The idea is that you try to place the patient's head there such that they can't really move easily. That in order to get good images from patients, that one thing that is really critical is the patient remain pretty much still over all this time. As I mentioned, MR tend to be fairly slow. And if you have a protocol that will require patients to stay there for not only minutes, but up to an hour, you have to have some mechanisms to actually control their motion. And this head holder is one of the mechanisms, turns out to be very useful for us. And also that having a head holder like this, we can actually, if we want to scan patients repeatedly, we can actually, by placing them onto the same head holder, they pretty much will go back to the same location relative to the first time, the second time, the third time, and so on. By doing this, we have a pretty effective way of tracking the progression of lesions by examining them over time. These are some of the aspects I'd like to talk a little bit. The first thing is the issue of flow suppression. That in order to do effective imaging of the vessel wall, the very first thing that we have to do effectively is to suppress signals from blood that happens to be right next to those lesions. This turns out to be not necessarily an easy thing to do. As shown here, that these are two images taken from a normal subject. On the left is an image taken with a technique, we call this a double inversion recovery. This was actually introduced by Dr. Edelman pretty early on as an effective flow suppression technique. This on your right is using a standard so-called flow suppression that usually a manufacturer will provide. And if you were to look at this image without having this image around, what you will see is this is the common carotid artery, the left common carotid artery of this normal subject. This material here that you see looks very much like a plaque. So you can easily misdiagnose that this is pretty extensive plaque built up in this patient, in this subject. But this subject really is in his 20s. It's very hard to imagine that you have something, and if you to look at this image here, that turns out with this type of flow suppression, you have a very effective way of suppressing flow. The reason why this region is so difficult to suppress is if you know a little bit about flow dynamics of the bifurcation region in carotids, is this is the region where the flow tends to be circulating rather than it's a streamline flow through. There's a region, especially at the carotid bulb showing here, that the flow becomes stagnant and is circulating within the region. This in MR is a tremendously challenged place of getting true flow if suppressed images. And at this moment, it seems to be that the effective way of doing this is use double IR flow suppression. The double IR flow suppression is very good for that point, but it is a very slow technique. That a normal way of doing this is that you have to do one slice at a time. So if one slice, it takes about 1 minute or so, and if you want to cover the cross-sectional areas of the carotids, that requires somewhere from 10 to 20 slices. That means just to get one set of images, it would take about 10 to 15 minutes. That's extremely long time to do this. So we have developed some of the techniques trying to make this faster, and this is one of the techniques we use. It's called multi-slice double IR. In this case, that we can shorten the time 4 to 8 times. These are the comparisons of the top image shows what is the traditional way of doing one slice at a time. The bottom image here shows that if you were to cut the time by using multi-slice, and this is saving time, you cut the time down 4 times. And this is what you see. You get pretty comparable images, but noticing that you do suffer certain signal loss in this case because of the time is shorter, the acquisition time is shorter. This type of multi-slice imaging can be pretty effective of looking at the distribution of lesions, like shown in this image. This is another one that this basically shows where the carotids is. If you were to use, rather than acquiring images this way, you acquire images this way along the artery. This is what you can get. This shows very nicely where the lesion is and the distribution of the lesion. And also that this type of images for us, when we do this in our protocol, that we use this little point here, this little flow divider as our landmark to realign patients if we want to do them repeatedly, such that each time when we do imaging, we pretty much bring them to the same location. And this type of oblique images of looking at where the bifurcation is, the lesion distribution, is for us, we use this as primarily as a land to achieve to obtain the landmark. This is a different view of looking from the same data set. The second thing we did is that we designed a protocol that we believed can actually provide the most useful information about the tissue composition of a plaque. We believe that in this protocol that it needs to have at least 2 types of images. One is flow enhanced images. This is the what I'm going to talk a little bit about. This is the internal carotids. In this case, this is the external, noticing that external is almost disease-free in this case. Internal, this is where the lumen is. And this is a time-of-flight image. You see the lumen very well where the flow is. You also see something of the wall, actually, in this image that actually turns out to be a fairly useful image. This is the same location on T1 weighted images. In this case, blood flow is suppressed. So what you see here is you see dark lumens in the internal carotid, also dark lumens in the external carotid. Also, you see there are different signal features in this that indicating different tissue groups you see in the wall. These are similarly taken with either proton density weighted and T2 weighted, and also that the flow is suppressed in either one of these. But you also notice that different tissues appear very differently, such that if you look at a lumen, surrounding a lumen, there's a bright band on T2, and it is not apparent on any other images. So what this tells you is that in order to get a fairly complete information about the tissue composition, that you truly have to look at different contrast weightings. This was documented very nicely by this publication from Mount Sinai in New York, and also by our group in '97. The third area is that once you get images like this, as a sequential stack of images of the carotids, start from the common carotid going up into the bifurcation and into internal and external, that you clearly can measure areas. And we have developed a snake-based algorithms and designed to track the lumen boundaries and outward boundaries. And once you can track those boundaries, you can pretty much calculate what is the lumen size, outer wall, and also you can actually use this type of data to generate a whole series of so-called morphological distribution of lesions, such as whether the lesion distribution is concentric or eccentric. By the way, that if you think about this in an intuitive way, a concentric lesion where the lesion is sort of uniformly distributed around the artery versus if you have a lesion that is very eccentric, where there are a lot of lesion built on one side of the lesion of the artery versus the other, that eccentric lesion usually pose much more danger than the concentric lesion. That's just intuitively saying. But this type of technique clearly can tell you that by not only looking at this, can give you all this quantitative information to describe those. And we have done a interscan variability study by bringing the same patient to the scanner twice within 2 weeks' time. And the assumption is there are no significant change over this time. And these are what you can get from time 1 versus time 2 at different locations from the same subject. What is actually interesting is if you were to look at this location here, if you were to measure the lumen of this diseased left carotids, in this case where my pointer is pointing to, and then you measure the internal carotid on the right side, which is almost completely normal, the lumen size is almost identical in these two cases. But look at this here, that the plaque buildup is fairly extensive already. That this really is a very nice example of the so-called expansive remodeling. There the lesion grow outwards first in an artery rather than grow inwards. So keep that in mind. If you remember anything from the seminar, is that stenosis doesn't tell you that information at all. So an accurate measurement of stenosis can only give you very limited information about where the lesion is and what lesion poses real threat to patients. And this is an overall variability that based on a study of 10 patients that was published in MRM in 2000. Overall, that if you were to look at T1, proton density, or T2 weighted images, the volume variations anywhere from 3.8 to 4.6%. This has been repeated by many other groups of looking at different arteries, and it seems to be the range of variation of volume measurement is of this area. This actually is comparing with the existing techniques of looking at vessel wall, that a real technique of looking at vessel wall is an intravascular ultrasound that you can bring a catheter into the coronary arteries to look at this. But that is a highly invasive technique, and the variability of volume measurement is actually higher than these numbers, significantly higher. Another thing that we look at also is based on area or volume measurement is we look at whether that lumen stenosis, as we measure clinically, versus what we're measuring now. We use one parameter in this. It's called maximum wall area. This is very simply derived from a stack of images looking at which location has the maximum area, plaque area in this case. And this usually can be labeled as a plaque burden. And we look at 37 patients, and it's all obtained from T1 weighted images. And the question we ask is, does the information of lumen stenosis, as reflected as the minimum lumen area and the maximum wall area, do they correlate with each other at all? What this shows is this is the distribution. There's a pretty weak association between these two with the R value of only 0.27. What this tells us is plaque burden really is an independent measure of lesion severeness versus what stenosis is providing. As I have been emphasizing that this is we are looking at a completely different set of parameters. They're directly measuring the lesion rather than that stenosis is an indirect measurement of lesions. And then the other thing, as I mentioned, is we try to use this so-called multi-contrast MR images to see whether we can actually determine different lesion types based on the AHA definition of lesions. And this is what we get. These are some of the sampled images of normal or early lesions. I think within the spatial resolution we can get of MR images, we really cannot tell the differences of an absolute normal artery versus a lesion that is a very early lesion of those. Usually those are labeled as fatty streaks in the deposit in the arteries, and we cannot tell the differences of those two. So we combine those into one group, and their appearances are shown here. Basically, it's a wide open dark lumen, and you see a relatively uniform bright ring that's surrounding that. That's a sign of a relatively normal artery. And then you can also look at almost the other side of this is the more advanced lesions. This is a type 6 lesion in the AHA definition. This is what the histology shows of what this looks like. The major part of the lesion is intraplaque hemorrhage. And then there's a cap actually formed here that actually is it's not very uniform, but it definitely exists. This is what you see on timeofflight images. Interestingly, that this region where the hemorrhage is looks about as bright as what the lumen would look like. So if you don't have black blood images like this to tell you that what this is, this image, the people may actually interpret this image by saying that there are two lumens in this. The flow is flowing there and also there. But this region really is hemorrhage. And it's actually that's showing very differently on the other contrast weightings. So based on images of this type, and also based on AHA deadline, AHA's guidelines of lesion types, this is what we come up with, what MR can do. This is the lesion type, start from relatively early or normal to up to type 8. Type 8 is a highly stenotic, fibrotic lesion. And if you were to look at the sensitivity and specificity of each group, start from type 3 to type 7, we have very reasonable sensitivity and very high specificity of detection. The only two groups we have relatively low numbers are one is the type 1 and type 2, and the other one is type 6. The reason we believe of this relatively low number on sensitivity on those is because we don't have enough samples. These are taken from patients who have had surgery. So we are truly looking at a very biased group of lesions. And if we started looking at a group of subjects like you guys sitting in this room, we should see a lot more in this group, relatively normal cases. This is a technique that we have been using to look at fibrous cap. This primarily is a time-of-flight based technique. And if you would look at these two images, on your left, this is the lesion, and this is where the lumen is, and this is where the wall boundary is. In between lumen, this relatively bright signal, you see this region that actually has giant bright signal in this region. It's indicating this actually is hemorrhage again. But separating this area to that area, there's a dark area that is separating the two. This we pretty much figured from the histology that this is a layer of fibrous cap or the fibrous tissue that separates plaque bulk to lumen. On your right here is another lesion that this is where the lumen is, and this is where the original wall is. And this gray area is the lesion bulk. And if you were to compare this image versus this image, you realize that this dark band sort of is not visualized. We usually label cases like this where the lumen boundary is still relatively smooth, but we cannot see this dark band as having a thin fibrous cap. In other words, that the cap thickness is below the resolution of the spatial resolution of those MR images we can get. This is a comparison of what we see in MR images, what we see in histology in this, that this is the lumen, and this is the plaque, and you see there's a little area, their dark band becomes discontinued right here. This is what the histology shows. That's exactly where the site where a rupture actually has happened. So it's a very nicely correlated study in this case. What is more interesting is that we, based on this kind of MR criteria of simply labeling lesions into three categories as ruptured cap, thin cap, and also thick cap, we look at whether this information we get from MR images actually correlates with the patient's symptoms when they're having surgery. This is the study that we looked at 53 patients. Among this, 25 are asymptomatic and 28 are symptomatic. The difference of this is really that patients at our institution, that whenever you have a stenosis over a certain level, for example, if it is 70% stenosis, regardless whether you have symptoms or not symptoms, all those patients will be operated on. That's why we have a fair amount of asymptomatic patients in this group. And we categorize the fibrous cap based on what I mentioned as a thick cap, thin, or ruptured cap. This is the overall profile of this two group of patients. The age, the gender, smokers, and also the, if you look at whether there are diabetes, hypertension, and whether there's this is the most interesting one in this group really, is the how stenotic are these lesions based on a Doppler ultrasound reading. None of this showed any significant difference at all between these two groups. And this is what you see based on cap readings that we see in MRI. With, if a patient's carotid lesion that we after we examine the entire lesion, we conclude that the fibrous cap exists and also it's thick. It's a thick cap. Only 9% of these patients have had symptoms. But on the other side, if we identify a patient had a ruptured cap, 70% of those patients have had symptoms. If you were to look at this in a different way of looking at the odds ratio of a patient who have a thick cap to have symptoms, if the odds ratio is 1, then it's 23 times more likely to have symptoms if the cap is ruptured. So this clearly shows that with this type of MR imaging we're getting some very useful information about plaque stability by simply looking at what the cap status is. The other area that seems to be very interesting is to use contrast agent in studies. This actually, in this case, there's 3 different patients, and we use identical contrast agent. Is clinically available. Gadolinium is a magnet. What is the name of this? Magnavist. But if you were to look at these 3 lesions, it shows 3 different effects. In this case, the lumen is right here. That it's very teeny, and then you have a giant plaque next to it. The layer next to lumen is significantly enhanced in this, and then you also see the adventitious layer enhanced in this case. This case is even more interesting, that this almost is a stereotypical so-called unstable plaque. The shoulder region of the cap actually has ruptured, and in this region there are pretty extensive microvessels built into this region, has a significant enhancement. And this region is almost completely non-enhancing, and this is the lipid-rich region. So by comparing this image and this image, you can actually get a fairly extensive picture of what the lesion, the tissue is. The third one is a relatively early lesion, and you see that there's a pocket of enhancement shown in this arrow region. There's also this little band that is completely not enhancing. So this contrast enhancement, in this case, clearly that helps. 1 is to look at, to see improved tissue contrast. 2 is that this type of imaging may actually tell you something about the activity levels within the lesion that as reflected by the distribution of macrovessels. This is a timeline of how we do this study, that we do pre-contrast MRI as a T1 weighted, and then we do a dynamic MRI. I will show some data just very briefly. And then we do post-contrast MRI. That usually is 3 minutes after the time of injection. And this is the parameters that we used in a study. This is what you would see in a dynamic phase of injection. This is pre-contrast, and you see the contrast gets in at this time. That usually correlate, it's corresponding to the second time when we do the dynamic study. And you see this, actually the signals from lumen washes out fairly quickly and gradually goes away. But if you were to play this as a movie, you actually will see that there are different phases of enhancement within the wall that you can visualize. That is shown here. But before we can actually use this dynamic data in an effective fashion, we have to deal with problems like this. This is how much motion you will see during injection. By the way, this is supposedly that the patient is supposed to hold still. And this is a 3-minute study, and this is what you see as a motion. Certainly, this is not a terribly good patient as far as keeping the motion still, keeping motionless. But we have to deal with this if we want to truly analyze the data. So Bill Kerwin, and he's currently actually it's a faculty in the lab now that developed a technique that can actually filter this type of motion out from the data such that a pixel-based analysis can be used for that. And this is what we find from a study that just published in Circulation recently, is we look at the fractional vascular area as determined by histology. In this case, we simply just measure microvessels we see in the histology map and add all those areas up as a fractional map, area map. This is what we can get with so-called kinetic modeling, use MR data, dynamic data, as a fractional blood volume seen within the plaque. And we showed, based on this many cases, I think this is 20-something cases, there's a pretty strong correlation between the two. What this tells us is that the dynamic MR study can probably provide information about not only where the macrovessels are, also how extensive are the macrovessels, whether that you have a lot of them or whether you have very little of them. In other words, we should be able to, based on this kind of a quantitation, to give not only where the macrovessels exist and also the extensiveness of those macrovessels. And then we also look at the concept of, suppose we look at so-called delayed enhancement. If we follow patients over 20 minutes of time, whether the enhancement we see in dynamic phase versus in the delayed phase, we're going to see differences. This again is a lesion that is showing here. On the left is dynamic data. This is what you see of the enhancement, start from the lumen to the wall. You also see the evolution of the enhancement within the wall. And then on this image here, this is a delayed enhancement of data taking from 3 to 20 minutes. By the way, in this case, we use a technique we call this a quadrilateral inversion recovery. That the idea is you can have effective flow suppression regardless of what the T1 is of the blood. That it turns out to be fairly effective for this type of applications. So looking at these two sets of data, that you can tell pretty clearly that the information we're getting from so-called dynamic phase versus the delayed phase actually are quite different. And we, at this moment, are analyzing this type of data, and we don't really have conclusive answers.
Carotid?
Carotid. All those are carotid arteries. The last thing I'd like to talk just briefly is that we have spent almost, I would say that within the lab, half of the people are concentrating this type of work is trying to quantify the information that we get from those images, those multi-contrast images. This is ultimately what we want to see is we can get images like this from different contrast ratings. We hope that we can integrate all this information into a map like this. This not only will tell you where the different tissues are, this will also tell you the size of them and their distribution. And this is ultimately where we want, and we have been developing a system called a quantitative vascular analysis system that with this as the major goal. At this moment, we have capabilities of looking at areas, volumes, eccentricities, and lesion distribution. And also that we have a pretty effective wall thickness measurement algorithm. The idea is that if you can get a lumen boundary traced, and if you can get an outer boundary traced, this algorithm can give you automatically what the wall thickness is where the maximum thickness is and the minimum thickness is, and also the mean across the entire artery. And also that the nice thing of this algorithm is that this is not dependent of the size of the lumen and also of the outer wall boundary. They could be of arbitrary shape. If you were to think about this from a theoretical point of view, is thickness definition is primarily coming out from circular subjects. That whenever you say thickness of a wall, the assumption is they have to be circular, or at least the worst case is some kind of oval shape. That's where you pretty much stop. Once this becomes an arbitrary shape, the thickness measurement becomes pretty much undefinable because of especially if the lumen is actually of some kind of funny shape. It's not a circular or oval shape at all. But this algorithm can actually handle all these cases to give you an answer that actually is in agreement with what the human would like to agree upon. So I think it's a pretty nice thing to have. I would like to finish my talk with two recent images that we have showing, one case is showing progression of lesion. This is a patient that we have followed over a period of 18 months. And this is the lesion you see at baseline. And this is the lesion that we see at 18 months. Between this time, patient has developed symptoms. And this is, so the patient had a surgery, and this is what you see in histology. That correlates very well of this lesion. And we are actually doing a study that it's a natural history study to follow patients this way to see that over this time, how does the lesion actually progresses from a type whatever to a more advanced lesion, and how that, what physically has happened over that time. Those information have not been available up to this point. The second one is actually a regression study, that this again is a patient actually is taking statins, is a cholesterol lowering treatment. This is what you see at time 1, and this is what you see at time 2. In between this time, this is only about half a year time. And you see that there are pretty significant change has already happened, especially at this location here. That the lumen is widened. You almost feel like that part of the plaque has washed out, that is basically is depleted from the artery. What is also interesting is you actually see there's some evolution that has happened within this region. At time 1, there are 2 pieces of calcium that is separated by some other materials in the middle. At time 2, these 2 pieces of calcium actually has pretty much merged into 1 piece. And whatever the material in the middle has basically disappeared in this. And this basically becomes a heavily calcified lesion with this treatment. And also the calcium seems to have evolved from a piecewise into a solid chunk in this. This again is a study at this moment, it's ongoing. So we simply say that we can see this type of changes by looking at MR images. And the implication of this at this moment certainly is going to be something that very interesting to look at. Yes?
How do you find the same location?
We use bifurcation as the landmark to realign patients each time. That's why that when we do a study, I show the carotid artery that is actually longitudinal, where you see the bifurcation. We always go back to that bifurcation each time when we do our protocol by saying, suppose if you want to do 15 images, we ask that the 7th image always is where the bifurcation is. By doing this, it has been fairly consistent where you can get each time in the progression or regression studies. So in summary, that high-resolution MRI that with the application of phased array coils and also the combination of using black and bright blood techniques, that we are able to look at a list of different tissues and different aspects. And I think that most of the so-called information up to this point about what a vulnerable plaque means is coming from histology. What this is giving us is that now we have a non-invasive tool. We can actually follow patients over time to see that what has truly changes in real patients. And we're hoping that with this type of techniques and with quantitative information about this different type of tissues, we should be able to come to a point of that it's an imaging-based vulnerable plaque definition that can be used clinically for optimal selection of patients for proper treatment. And then this is, I would like to acknowledge the group of people that I work with, that this clearly is a multidisciplinary project, involved people from radiology, pathology, electrical engineering, and also statistics consulting. And then this is the group of people that we work with. And its funding is coming from NIH and also from pharmaceutical companies. Thank you very much.
When you do those T1 weighted images, do you gate them?
We don't gate on T1.
No.
I think that if you look at a younger generation of patients, that gating is more important. But for this type of patient, most of the patients we do are in their 60s and 70s, that the arteries are hardened enough that they don't move much at all during the heart contraction.
And I don't know if you mentioned the resolution of these images. What's the resolution?
The resolution is the pixel size of most of those images you see are 0.25 by 0.25 millimeters. And the thickness is a 2 millimeter thick section per image. And that's the pixel size, but that is after the interpolation with a Fourier, so-called zero-padded Fourier transform.
What's the original?
So the real resolution is 0.5 millimeter in those images. Yes?
I think this is all 1.5.
Yes.
My two questions would be high field 3T or 7T, would that help? And number two, what about more massively parallel phased array coils, 20 elements? Would that help, or is it too close to the surface?
I think carotids is whatever we get is pretty much optimized. It doesn't really, by giving more, we have actually, since we designed those coils were first published in '96. We have actually looked at different designs, whether we can improve the signal. We have not been able to actually, for whatever reason, the first round of design actually turns out to be the optimal design. But 3T for sure will help. We have actually just gotten some recent images with a duplicate design of the coil that works on 3T. We got beautiful images at the first run. So I believe that 3T will definitely help. I don't know what will happen with 7T in this case, or higher field. For carotids, I think that the subjects are relatively superficial, so may be beneficial. But you also have to deal with, this is an area that you have a lot of interface between bones, hairs, fat, and so on. So the susceptibility will become a real problem in that area. I think my model of coils is, I believe that in 20 years' time, but you can't quote me, is that every patient will wear a clothes that is coil build. And then when they're getting into the scanners, you just flip on different coils at different body parts and you get this. So in that sense, I think this multi-coil design will probably be beneficial for certain aspects of this.
I thought they just come in with their coat hanger.
They probably should. Yeah.
I have a question from your experience in looking at different patients and different components of the plaque. What do you think is the value of actually seeing calcium? How is that affecting the risk and the value of intravascular or intralesion angiogenesis? How do they relate to?
I think that's actually it's a very interesting question. I believe that calcium cannot be interpreted in one sentence. It can be, I believe that if you, I don't know whether you follow the literature that Reno Vomani published, that she's this I think is almost viewed as the pathologist now doing vascular biology and looking at. Her data showed in coronary arteries that there are pretty significant proportion of patients actually, the cause of death is because of calciums happens to be on the surface of the arteries. Those are, but there are also data showing that calcium seems to be is the healing process, the remodeling, and it's, if you see calcium is already at a later stage of lesion development. And we believe that this should actually be looked at in many different angles. I believe that certain type of calciums may be good, certain may actually be bad. I can imagine that a plaque with solid chunk of calciums at one place and neighboring with a soft plaque on the other can be stable because you have this pretty mechanical stress right in the interface there.
So that would suggest that the statin treatment actually brings instability.
I was hoping you wouldn't get there, but
That's
nobody knows. That clearly that calcium is changing when you have statin treatment, and what's the effect of that at this moment? I think it's remained to be seen. Yeah.
There's been sort of a lot of interest in sort of the fluid mechanics of wall shear stress here in vessel walls, and I was wondering if you had any idea or any thoughts about, you said some of these lesions have thick fibrous caps and some have thin fibrous caps. Do you think that's only due to the patient's, say, immune response or the cellular level, or does it have something to do with the shear stress or the wall stress for pressure variation? Any clues on that?
I think it has a lot to do with that. I think that seems to be it's a very strong area of Georgia Tech and Emory here that should really be studied. And I strongly believe that has to be the impact of this cannot be just if you believe that lesion, the so-called the early lesion development has everything to do with the flow dynamics and the shear stress of the area, and then you say this has nothing to do once the lesion develops, that's just not possible. I think it's definitely going to be an interactive. People will find out that it's an interactive relationship.
Okay, let's thank our speakers again.
Thanks.